Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. Last week, I did the first show introducing the public to what this disease really is and what's the genetic of it, etc. I'm going to repeat some of that in this segment and then proceed to begin to talk to you about the different sickle cell crises. Before I do so, however, I need to once more take a few seconds from you to introduce you to this book, The Best of Clinical Medicine for the 21st Century. This is a book that I wrote that came out about 6 weeks ago. It's a very big book. It has 110 chapters, 816 pages. It covers medicine not only in America but throughout the world. If it has to do with modern clinical medicine, the latest of everything, it's in this book. Take a look at it. It can be found in your local public libraries as well as online, and there are always copies in my office. Okay, now, sickle cell disease. It's a very, very bad disease. It afflicts millions of people, and it is a genetic disease that was discovered in this country in 2019-10, the clinical part of it. But subsequently, the basis for it, the biochemical basis of it was discovered by Dr. Linus Pauling by doing basic biochemistry research. He discovered that the substitution of valine for glutamic acid at position 6 of the beta-globin chain is basically what caused this terrible disease. And of course, he went on to get the Nobel Prize for this discovery. And this particular discovery gave birth to what is now known as molecular biology, molecular genetic, molecular pharmacology, everything having to do with chemistry and etc., genetics, etc., all became what they are today because of this original biochemical research that was done by Dr. Pauling. He got the Nobel Prize for that. I think he subsequently got Nobel Prize again for peace because he was involved in the peace movement very seriously. Now, the genes that cause the disease, there are three main genes, really, three genes. One is called BEN. It comes from the part of Africa, from Benin. And then the other one called CAR, stands for Central African Republic, and then you have SEN, S-E-N, from Senegal. Those are the three genes that cause sickle cell disease as we know it throughout the world. In this country, there are roughly 100,000 folks who suffer from sickle cell disease as we know it, the S, sickle cell disease. Then there are 3,600,000 people who carry sickle cell trait in this country. And throughout the world, there are roughly 300 million folks who have sickle cell trait. To give you an example, in Nigeria, they have 4 million people who suffer from sickle cell disease. It's very, very painful and extremely crippling disease. If an infant is afflicted with it, they begin suffering from it since they're in the wombs of the mothers, and research have shown damage to the brain of the fetus while they're still in the mother's womb. So, and once the child is born, he or she is pretty much doomed to having a life of in and out of the hospital, requiring pain medication and blood transfusion, etc. It's a very, very bad disease. And in this country, in 1910, a cardiologist in Chicago was taking care of a young man called Walter Clement Noel, who was from Grenada, studying in Chicago to become a dentist. And he got sick, wound up in the hospital, and Dr. James Bryan Herrick, in conjunction with his intern, Dr. Ernest E. Irons, discovered under the microscope that there was something wrong with the shape of the red blood cell of this patient that they were taking care of, who was having excruciating pain and hemolyzing, etc. Hence, the discovery of clinical sickle cell disease in North America. The percentage of people who carry the sickle cell gene is 8% in black in this country and 8% in Latino in this country. The percentage is the same. There are many states right now where it is required by the health department for the cord blood of infants who are blacks and who are also Latinos be tested by doing hemoglobin electrophoresis to see if, in fact, they are not carrying this abnormality. And that has a tremendous importance, even in the infancy and the pediatric age group, because these people start getting sick very early. It is important to know whether they have this disease or not because of the way they present the emergency room and the frequency of the recurrent diseases such as infection, etc., as they suffer from. So that's the law in some states. I know it is the law in New York City anyway. So you have that many people who have this particular disease. You wonder, well, what happened to the cell that makes the disease so bad? Well, I have here on the screen to show you what a sickle cell look like. It's see this half moon shape or banana shape with a little arrow pointing. That's a sickle cell. Look at how malformed the cell is. And over here, I will show you a normal red blood cell. See, this is a normal red blood cell. This red blood cell is not normal. It's for different reasons. But it's a normal red blood cell, disc shape. And this red blood cell is able to change its form by when it's passing through the tiniest little arterioles throughout the body. No matter how small the vessel is, the red blood cell is made in a way so that it's able to navigate through it in order to deliver oxygen. The hemoglobin that the red blood cell is carrying is to which oxygen is attached, and the red blood cell carry oxygen throughout the body. Unfortunately, the sickle cell cannot do that. Cannot do that because the cell, as it tries to navigate through this vessel, it gets stuck because, number one, it is malformed. Number two, the cell is very sticky. And the stickiness of the cell creates a major medical problem itself. Not only that it causes it to get stuck, but the very fact that it gets stuck to the vessel, it damages the wall of the vessel to which it is stuck. And consequently, that creates a local inflammation. And once you have local inflammation, the next step from there is, of course, plaque formation. So that is why sickle cell disease is such a bad disease. Sickle cell disease affects entire human body. There's absolutely no organ in the body that sickle cell does not affect to one degree or another, because cell has to go everywhere. Here I'm showing you this is an example of a joint. Okay, see right there? This is called, this is avascular necrosis. This bone is gone. Blood cannot go through. See, avascular necrosis. This is an example of what happened to this joint. It's finished, gone, dead. Has to be replaced by the orthopedic surgeon. And because lack of oxygen causing ischemia to occur, and damage it, avascular, meaning no vessel can go through, and then you have avascular necrosis. This is example of what happened to the bone. Now, it is a bad disease. Now, I'm going to begin to talk to you a little bit about the different type of sickle cell crises. And there are hemolytic crisis, that is to say the red blood cell hemolyzes, it bursts. Why does that happen? It happens because in sickle cell disease, the cell does not live to be 120 days. The normal red blood cell that I pointed out to you lives in the human body for 120 days. But the sickle cell lasts somewhere between 30, 20 days max because it gets destroyed. It hemolyzes. So hemolytic crisis is the number one crisis in the person who's suffering from sickle cell disease. And there are four major types of diseases associated with sickle cell. Number one is the SS, the homozygous SS. Number one is SC, like in this case, this study that I'm showing you from a patient who suffers from SC. That's when the S gene was associated with the C hemoglobin. Somebody, either the mother or the father, was carrying the C abnormality, hemoglobin C, which is an abnormality, and the father or the mother was carrying hemoglobin S, which is the sickle cell. And when the child is born, you have a combination of SC disease. Okay, so that's S. You have SS, SC, and you have you have sickle thalassemia. Now, sickle thalassemia is the same situation, namely, a mother or father was carrying the beta thalassemia gene as an abnormality, an abnormal hemoglobin, or the mother or father was carrying the sickle cell gene, and they get together, create an infant, and the infant will inherit hemoglobin sickle thalassemia. So and then you have hemoglobin, you have sickle trait, which is SA. So you have SA, SS, SC, and sickle thalassemia. Each one of these things have different clinical presentation and different syndrome. But the basic abnormality is that when somebody has SS, SC, or sickle thalassemia, they have about between 60 to sometimes 70% sickle cell circulating in the blood at any one time. On the other hand, if somebody is carrying the sickle trait, they have about 60% good red cell, roughly between 35 and 40% sickle cell. That's the percentages that goes around, okay? Okay, so you have the hemolytic crisis, then you have painful crisis, then you have what's called hypoplastic crisis. What is that? Hypoplastic crisis is a deadly situation, namely the person suddenly shut down the bone marrow. They're not making red blood cell, period, and it's deadly. And when I get through them, I'll explain to you how that is discovered and how it is treated. And then you have what's called splenic sequestration. That's not a form of crisis. Then you have what's called acute chest syndrome. That's another sickle cell crisis, which is can be extremely deadly, especially if it is missed when the patient presents with it. I mean, modern days, you have a dead patient. And then we have what's called priapism. What is priapism? Priapism is a condition whereby the red blood cell gets stuck in the man's private organ, namely the penis, and he has a massive erection, which is supremely painful, and then I'm going down. It's very painful. And the man is really walking, jumping around. It's not going down. And there are ways we go about treating that, okay? Also, you have to understand people with sickle cell disease also bleed from the kidney. That's correct. They can come in with gross hematuria or they have constant microscopic hematuria, blood cell that can be seen only under the microscope. That's called microscopic hematuria. And they have gross hematuria. For a reason that is absolutely not clear, at least not to me, people with sickle cell trait also bleed, but they have the propensity of bleeding grossly, gross hematuria, pure blood coming out of the kidney. And the reason that is because the sickle cell gets stuck in what's called the papillae of the kidney. And because they get stuck there, oxygen is not going through properly, and they develop what's called papillary necrosis. And because of the papillary necrosis, they bleed massively from the kidney. And then they have to be admitted to the hospital. We have to do all sorts of stuff that I'll be telling you about on how to try to stop this bleeding. And then I'm telling you for a reason that is not clear to me. It occurs more. Everybody with sickle cell disease have microscopic hematuria. We know that. When you see somebody present in your office, you happen to do an analysis, and they have microscopic hematuria. If it's a man, it's always abnormal. If it's a female and it's not within the time where she's having her period or she's postmenopausal or what have you, it doesn't belong there. So you have to work it up. There's a whole differential diagnosis, including cancer, kidney stone, infection, etc. But if the person is of certain ethnic groups, such as Latino, Latina, Black, men and women, children and whatever, you have to make sure that you don't miss the fact that they may be having an abnormal hemoglobin, in this case, the sickling hemoglobin. Those are things that we teach medical students, intern, and resident not to miss. Okay, you absolutely, you want to do one's best not to miss any diagnosis, but there's certain you just absolutely cannot miss. Okay, so that gives you an overview of the different type of crises. Okay, now let's spend the rest of the time talking about hemolytic crisis. Okay, the patient with sickle cell disease, be it SS, SC, sickle thalassemia, they go around carrying a hemoglobin somewhere around 9.5, 9.6, 10.0 gram, hematocrit somewhere in the high 20s, and they do fine. They do fine because they get used to it. We don't get very nervous about it. But every now and again, for a reason that is not clear other than maybe stress or an infection, they begin to hemolyze briskly. I mean massively. The urine is basically dark looking because of the breakdown product of the red blood cell that's being put in there by the filtering out by the kidney. The eyes is extremely yellow. I mean 4+ yellow. We grade scleral icteris from trace to 4+, massively yellow. The skin is very yellow, and the patient hematocrit drop acutely to the high teen or low 20s. Okay, so that's acute hemolysis secondary to the sickle cell phenomena. That's the sickle cell. That's the hemolytic crisis, and then you would evaluate them clearly. Of all the tests that you are going to do, the most important test in this setting is the reticulocyte count. What are reticulocytes? Reticulocytes are baby red cells. Why are they so important in this setting? Well, when someone is hemolyzing acutely, no matter the cause of the hemolysis, I happen to be talking about sickle cell disease now, no matter the cause of the hemolysis, the body is attempting to replace the red cell that's being lost by dumping a tremendous amount of early baby red cell into the system. And we then take the blood, send it to the lab. In the lab, we will make a smear of this blood that we just received that is anticoagulated, and then we will stand the stir with Gram Gimsa. Now I can talk authoritatively about that because I spent years being a medical technologist, and I must have done thousands of those. And then we will count 100 red blood cell, and then the percentage of reticulocyte that is found within that 100 red blood cell, that's the percent of reticulocyte. A patient with sickle cell disease is expected to walk around with a high reticulocyte count somewhere 6, 7 in that range, which is fine. However, when it's jump up all the way to 10, 12, 15%, that's when the patient is acutely hemolyzing. And the body, because the body is capable of doing that, the bone marrow is dumping reticulocyte into the system, and that tells us the patient is really is not bleeding. Why the hematocrit is so low? There could be, because sometimes you could have 2, 3 problems going at the same time. But keeping the discussion to sickle cell disease, this patient is briskly hemolyzing. Also, the liver function test, the indirect bilirubin is going to be very high. You have direct bilirubin, you have indirect bilirubin. Direct bilirubin occurs when something happens to the liver. There's an obstruction of the bile flow. The bilirubin shoot up. That's direct bilirubin. When somebody is hemolyzing, dumping the bilirubin into the red blood, so that's the indirect bilirubin. Those are medical terms, and I'm speaking to an audience that also involves medical students and physicians and nurses that listen throughout the world. So that's what those things are. Okay, now that has to be addressed acutely. We would admit the patient to the hospital clearly, do a complete evaluation, look for sources of infection. It could be infection of the urine. It could be pneumonia. It could be God knows what infection. It could be a viral infection or stress or what have you. Then we will proceed to treat the patient. Well, the best way to treat this patient acutely is by giving the patient blood transfusion. That's why red blood cell transfusion is the #1 treatment in acute hemolysis in this setting, okay? And sickle cell disease. You give the patient red blood cell, and if the patient is somewhat older, they have an enlarged heart, you got to take that into the equation by appropriately treating the patient by giving them intravenous Lasix and oxygen. You give oxygen anyway, nasal oxygen, but you have to give them Lasix because they have an enlarged heart, and you can transfuse them sometime with 2, 3, 4 units of blood, and never give somebody who's chronically anemic too much blood at the same time. That is a dangerous thing to do. They are anemic. They've been anemic for a long time. The body is used to it. There is absolutely no reason to flood them with red blood cell because red blood cell is very viscous. Once you put it in, you can't take it out. And if you dump too much in there, you're going to wind up throwing the patient in acute congestive heart failure. That is clinical medicine. You don't do that. That's a no-no. You make sure the patient gets sufficient amount of blood, and you give them IV intravenous Lasix so that they don't get over-transfused with too thick blood that is too thick. It's very, very important that you know what you're doing and you do that effectively, okay? Now, that is what hemolysis is. Hemolytic crisis is a major problem. Major problem. Major problem hemolytic crisis is. Now, that's how you go about doing that acutely to save the patient's life so that you give the patient enough oxygen carrying capability by giving them blood. Now, you got to listen to this. I read something yesterday. I couldn't disagree with it more, and it's a hematology journal, and I have the right to disagree. Completely disagree with it. The blood in the blood bank is now allowed to stay there for 42 days, okay? You got to listen to the story, why I told you I disagree with it. As the blood sits in the blood bank, it releases potassium. It also releases 2,3-DPG, which is not going to tell you what that is, but it is important, 2,3-DPG. The longer the blood sits in the blood bank, the more potassium, because as the red blood cell get destroyed, they release potassium. Granted, good amount of material support in the blood to preserve the blood so that it can last 42 days. But also you're losing 2,3-DPG. Now, if I'm going to transfuse a patient who has severe heart disease, which can happen in a sickler, because the sickler began to get sick since he or she was in utero. So since childhood, this infant or child been going to the hospital back and forth to be admitted to get the blood transfusion. And these folks are very anemic, and they wind up with secondary hemochromatosis, which then damages the heart. Damages the heart. The heart inevitably is going to be enlarged. Sometimes they have severe cardiac arrhythmia. Sometimes they're in and out congestive heart failure. So they have ischemic heart disease secondary to the sickling phenomena. So far, so good, okay? Right, here it is. So the person is very anemic, and I'm going to transfuse them. Now, if I have experience in clinical medicine, I'm just talking about scientific stuff, what am I going to do? I am going to give the patient the freshest red blood cell I can find. They say, but why? I mean, are you wasting the blood? Of course not. I'm practicing excellent medicine. How? Explain to me. Well, if you give somebody blood that is 2,3-DPG deficient, as our blood that stayed there for a long time. Somebody's bleeding massively for bleeding, cats, that's different. But if somebody had underlying cardiac disease, I'm going to give him blood transfusion with blood that is deficient in 2,3-DPG. Guess what's going to happen? We have a curve, what's called oxygen dissociation curve. Don't bother what it is. It's an invisible curve. There's the right, there's the left. Okay, now, if I give this patient 2 units of blood, sometimes they get 3 in one day, and the blood is deficient in 2,3-DPG. This blood is not capable of carrying oxygen properly. So as I infuse the blood into this patient, I'm pretty much doing the patient more harm than good. You say, well, how so? As soon as the patient gets the 2,3-DPG deficient blood, he or she is going to shift his or oxygen distribution curve to the left. Absolutely, going to shift it to the left. And as you do that, the red blood cell is holding onto the oxygen, will not deliver it where it's supposed to go to perfuse the organ. Will not. That's the point. So therefore, you cannot justify giving someone 2,3-DPG deficient blood who has underlying ischemic disease. Because if you give them good blood, fresh blood, that has enough 2,3-DPG, as soon as they get the blood, they shift the oxygen distribution curve to the right, and this way the red blood cell is able to release the oxygen that it's carrying to perfuse the different organ. You understand that? And when I read this yesterday, that's not what that was talking about. It was talking about the commercial reason why red blood cell that's kept in the blood bank for 40 doses is still good. But this person who wrote this clearly misunderstood or doesn't know or don't remember about the oxygen distribution curve as it relates to the need to perfuse the organs in the body properly. Because if you do that, you could cause an acute heart attack. That's right. You could acutely make the patient more ischemic and cause an acute heart attack with all the complications they are. Now, this is clinical medicine. You can't just take everything you read at face value without dissect it to completely comprehend the physiology behind it. So when I wrote that yesterday in journal that I'm a member of American Society of Hematology, I was taken aback. I'm sitting there by myself. I said, "Are you serious?" You know, of course, the blood is good for 42 days. That's the rule of the game. That's the rule of the country. You could use it in different sort of settings, but not in a patient who has ischemic heart disease. You cannot, absolutely cannot. Or ischemic brain disease. You could cause a stroke or an acute heart attack if you do that. Listen, I'm going to stop here. Next week, I promise you, I'm going to continue to talk again about hemolytic crisis. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.